بسم الله الرحمن الرحيم. السلام عليكم. We continue, inshallah, our review. Yes. So in this one, what we call it, endometriosis. Why endometriosis? One of the good differential, as we mentioned, that make extrinsic effect in the barium. So when you find this appearance, you should put in your differential something which is endometriosis. Let's shift to this case, which is a bit easier one, antimony case, especially with the CT. Yes, and he show you the annotation with arrows. Yeah, the desmoplastic. Okay, I agree. Yes, mucosal. So Marwan Rubin, perfect. Yes. We have here like multi answer, which is very perfect, really nice. So mass effect in the cecum, and when you see, you can see like oblong shaped cystic lesion, which is filled by hypodense material, which is supposed to be like the mucosal. Perfect. Let's shift to another one, and here you can see that the pathology in this case, so this one is a structure here, and this one another structure here. So this is what is called synchronous tumor, which is you have multi lesions. Yes. So with this adenocarcinoma. Let's shift to another one. With this patient have history of chronic ulcerative colitis, and he get remission. Yes. So what do you see here? Maybe, but already he have like history of ulcerative, not Crohn's. So do you agree that there is multiple lesions that maybe denote that there is like a polyp? Yes, with this double contrast barium enema. So maybe it is a polyp. Yeah. Again here, what is called like Fili. Let's have a look. Filiform polyps. Yes, this is like filiform polyps. And I agree with you, pseudo polyposis. And he mentioned that it can be seen with normal mucosa or recurrent disease, as we mentioned in this case, which is ulcerative colitis. Yes, also can be seen in Crohn's or any inflammatory condition of the colon. So I agree with you, without history, and you see this appearance, you put differential diagnosis and sure that filiform polyps or pseudopolyps, this is the nice answer. Yes. Let's shift to another one, which is, we mentioned it before, with this appearance is characteristic for Rihan. Yes. Marwa. Thumb printing, perfect. So when you put your thumb here and you can put it in submucosal edema or hemorrhage, it is thumb printing. So you know that maybe there is some submucosal edema or hemorrhage. Yes, and in the CT is much easier with marked mural thickening, and you can see that the contrast like entrapped between the house trap. Perfect. In a accordion sign. Yes. So this what is called pseudomembranous colitis. It will be your top of differential diagnosis in this case. One very important to know that in this patient, not supposed to do barium enema if you suspect. Why? Because there is a risk of perforation. So next step, don't mention that pseudomembranous colitis if it is suspected. Don't go for barium enema. The differential sure that include other causes like ischemia, ulcerative, or maybe some infectious colitis. The appearance, we already mentioned the sign, accordion sign, right? Yes. Let's go to another case, which is differential sure. Yeah. So differential could include, yeah, ulcerative, yes. What else? Infectious colitis, Marwa, perfect. So yes, so cytomegaloid, which is something from the infectious, can be included. Yes, nice. So let's go to another case, which is show you like, yeah, sorry. Why ulcerative, Marwa? This is supposed to be the normal colon, but this is supposed to be the abnormal colon. Yeah. So this is what is called lead pipe, a haustral left colon. Yes. So when you see this, you suspect to be ulcerative. Nice. Another image for this case, you can see clearly that the haustration appearance, it is disappeared here, right? Yeah. So that's what you can think about ulcerative colitis. Nice, Ala, that you can mention that also maybe it can transform to carcinoma. Yes. So this is the increased risk of colon cancer. Perfect, Ala. So it have many findings: granular appearance, stippled appearance, and the distribution of disease is very important, that start from the rectum without skip areas like Crohn's. Crohn's have skip areas. Here, this one have continuous form, okay? And as you know that maybe, yeah, the mucosal ulceration affect both sides and lead pipe colon, yes. And don't forget that to search for colon cancer, especially for CT. Okay, Marwa, perfect. Okay. Differential diagnosis will be infectious colitis and something called cathartic colon. Yes, okay. There is some extra intestinal manifestations. Don't forget the sacroiliitis, as you know, and cholangiocarcinoma, primary sclerosing cholangitis, and some skin manifestation. They like it in MCQ, yes. Let's go to another case, which is very famous in the exams. No? Let's, yeah, why Mirizzi? What is Mirizzi syndrome? Yeah, there is indentation, and this indentation affect the, yes, this is supposed to be the common bile duct, yes. And when you find like narrowing or compression of the adjacent common bile duct, or maybe sometimes common hepatic duct. So when you have this indentation on, yes, compression of the proximal common bile duct or the hepatic duct. So this may be from the stone impacted in the gallbladder, cystic duct, yes, or the gallbladder neck. So it show you this indentation, yeah. And maybe, as you see here, that the intrahepatic ducts are dilated. And if you have ultrasound or maybe CT, you can see the cholecystitis as well. Yeah. So also you can see in the CT the, yeah. So can see here clearly the filling defect. Yeah. Adjunction of cystic duct and the common hepatic duct, and this make obstruction. And I think they have also ultrasound here, and they show you the stone with shadowing, and that's what is called Mirizzi syndrome. So again, where there is impaction happen in the cystic duct or gallbladder neck and make indentation in the common bile duct or common hepatic duct and make intrahepatic biliary radicals dilatation, then you can think about what is called Mirizzi syndrome. So what is Mirizzi syndrome? Stone impacted in cystic duct or gallbladder neck and make compression or narrowing of the adjacent common bile duct or common hepatic duct. Perfect, Marwa? Ala, nice, perfect. So usually narrowing is eccentric, worse in the right side, may be dilated, and the most important that it have cholecystitis. Okay. So let's shift to another case. I think Nermin, who answered it last time, maybe she can know it easy this time. I think Nermin or Marwa, one of them who liked this case last time, but it wasn't the answer. She understand what I, yeah. So imagine that this is the duodenum, okay? Yeah, maybe this now is easier. Yeah, so perfect. Yeah, so there's narrowing here, and the narrowing, as you see, it is a smooth narrowing. It is not malignant stricture, or it is like benign narrowing. Yes. So when you find benign narrowing, try to find other differential for this. And I make ARCB and show you that there is, yeah, what happened here when he inject the contrast through the pancreatic duct. No, it is the same case near me. It is the same case. What happened here? The pancreatic duct branch in circle. Yes, make like a circle, صح? Okay, within the duodenum. So this is like proof for you that this case, it is what is called annular pancreas. And then CT, it is much more easier that you can see that the pancreatic tissue is completely encircling the second part of duodenum. So again, this is barium, ERCB, and the CT appearance. Yeah, it is surrounding the second part. Perfect. So this is what is called annular pancreas, which is encircled second part of duodenum, abnormality in rotation of pancreas or duodenum. Yes, the complication, sure that you will search for pancreatitis, and if there is any obstruction of the duodenum, and the treatment is surgical. Okay, so let's go to another case. I am a bit faster because I know that we need to figure out much cases, so let's go more and more. So this one, sure that it will be differential, but let's talk that, describe it. Yes, try to describe it. So why abscess or hydatid? Because you have multiple coalescing cystic lesions, and there is septation. Yes, and this septation have some enhancement. Yeah, so maybe the pyogenic abscess, one of the good differential, or hydatid. Yes, I agree with you. And this one, it was pyogenic abscess. So why pyogenic? Maybe pyogenic, maybe abibic, maybe hydatid. Okay, so the pyogenic is something gram negative. Okay, and it comes from hematogenous spread from portal vein or hepatic artery, and direct spread from adjacent organ or trauma. The major, yeah, the right loop have the major part, and 2/3 is multiple. As you see, the septation is something characteristic, and some of 20% have gas. Yes, the amoebic one, yeah, it tends to be unilocular, and the hydatid, you will see maybe smaller daughter cyst within the large cyst, and there is something called water lily sign, which everyone like the sign. So this one should be the Marwa. Yes, amoebic, perfect. Nirmin, Ala, perfect. Our stars always. Yes, so this is one should be the amoebic one, and this one should be the hydatid with the daughter cyst, right? Perfect. So this is what's called echinococcal cyst, and again this one will be the biliary. Well, yeah, that's one. Another one which is differential, it is the biliary cystadenoma, where you can have like large multilocular cystic lesions. So it is differential. Sure that you will put the pyogenic and the highlighted one of the differential, but don't forget something called biliary cystadenoma. Yes, differential diagnosis of biliary cystadenoma. Perfect. So this one also we have looked in the last session about when you find this, you are going to mention that is it necrotizing or non-necrotizing? So it is perfect. It is necrotizing pancreatitis. Why? Because no enhancing viable tissue. Then you should search for complications and what is called wall of necrosis. Perfect. So this is what's called acute necrotizing pancreatitis. When you find acute fluid collection in the pararenal space, anterior pararenal space, yes, and you can see the necrosis, how it affects the pancreas. I mentioned again that there is one very good article in the Radiology Assistant I showed you last time, and you can just read it. It's very helpful, and they have recent updates. So when it doesn't enhance in the post contrast, so you are talking about necrotizing. Yes. So let's shift to another case. Yes. So let's have differential. Yeah. So you have fluid collection, which is very important to mention, and you have enlarged liver, and you have different densities in the liver. And maybe if in the real practice, I will mention that it could be something malignant and something metastatic, and you will put your differential, sure that it will include like a masses. But there is some helpful maybe signs that can, yeah, look in the vessels, so the hepatic vein of the vessels, and also the appearance of the lesion. If it is a geographic area and the vessels don't have any mass effect, can cross traversing clearly. And he did MRI, so this should be the T2 fat suppression. And again, you have the collection, so steatosis, perfect. So this is a case of steatosis, and here you can see clearly in T1 that there is no mass appearance, so you cannot see any mass in this case. In the T2 also there is difficult or hardly to can differentiate that there is masses, and also you can see the vessels clearly go in normal way, right? But in the CT, yeah, sure that you will suspect that there is could be a mass. In the MRI, it is much more easier that the vessels, intrahepatic vessels, it much go normally. Marwa, yes, nice. T2 fat suppression, yes. And yeah, maybe the patient, because the ascites, maybe have something else that make it ascites. I don't know. I don't know the history of this case, but in the T2 gradient, which is out of phase image, yes, what happened here? Compared to the T1, this is the T1, you cannot easily differentiate it, but in the T and the out of phase, there is something called drop, yes, Nermin, drop of signal or loss of signal. So that's what is called steatosis. So you can easily determine the hepatic steatosis. Focal fat versus tumor, look for geographic borders, interdigitation of borders, the adjacent liver, lack of mass effect, especially the hepatic vessels, and rapid change over the time, okay, and it can resolve in weeks. The most important MRI that you look for the out of phase signal. Why? Because it have macroscopic fat or microscopic fat. What is the type of this fat which is suppressed in the out of phase? It is macroscopic or microscopic? Yes, it is microscopic fat. So, and which fat should suppress in the T2 fat suppression? The macroscopic fat. Yes, that's right. Okay, so let's have another look for this case. Yes. Why lymphoma? Sure that you will mention sandwich sign. Perfect. Marwa. Nermeen, Ala, mashallah, you get high score, inshallah, in every exam. Elevated aorta, this much important to mention. Yes. Ala. Why? Because there is another disease which the aorta doesn't elevate it, which is the retroperitoneal fibrosis. So how to differentiate between retroperitoneal fibrosis and the retroperitoneal lymphadenopathy, as in this case, because the space between the vertebra, for example, or retroperitoneal area and the aorta is increased. But in the, yes, and also floating aorta sign, nice. So Rihan, the displacement is very important, that help you to differentiate between this and this. So in this case, as we know, in the staging of lymphoma, when you find the retroperitoneal lymphadenopathy, maybe it is metastatic and maybe it's lymphoma. So what you are going to do, most of the clinicians, they go for FDG PET-CT and they make like assessment, initial assessment, or maybe follow-up assessment. So don't forget to mention like the regions of lymph nodes, especially the spleen, which is a tricky site for lymphadenopathy. And as you know, even in the staging of lymphoma, you have like special staging for spleen, which is 3S, when if it is involving the spleen. So it's important to know that the spleen is one of the nodal sites that we should have special consideration, okay? And also to know the extranodal sites of lymphoma and the nodal sites, so splenic and nodal lesion or extranodal sites, okay? It can come as a long case, yes. So another case, which is a bit easier one, maybe short case. Yeah, pneumoperitoneum, free air in the abdomen, which is easier one. Yes, pneumoperitoneum, and the CT, you can see clearly the air, so that's what's called pneumoretroperitoneum. Yes, the sites, pneumoretroperitoneum. So this retroperitoneal air, yeah, the location in the, yeah, more fixed in location than the peritoneal air, tend to be linear in shape. So this is retroperitoneal pneumoperitoneum, right? Not pneumoperitoneum. Let's have a look again in this case. Yes. So it can happen like with trauma, inflammatory disease of retroperitoneum, gas producing organisms. Yeah. So they have three spaces, which is the perirenal space, and in the axial you can see the anterior pararenal and posterior pararenal. So this is the common sites for the retroperitoneal air, right? Yes. Perirenal space and anterior, you can see it in the axial and posterior pararenal spaces. When it is linear, then you are going more with the pneumoperitoneum. Yes. So more fixed in location than the peritoneal air, which tend to be linear in shape. Yes. This one is much easier, and everyone in the practice should pass with this one. Yes. So it is hemangioma. Why? Because it have interrupted century. Yes, interrupted. Yes, nodular enhancement and centripetal. Yes, interrupted, and it have centripetal. As you see, it fell in with the staging. Yes, with the phases. So this is what is called cavernous hemangioma, which is the second most common solid tumor after METS. Yes, So everyone see it. The most important to know that maybe it have hemorrhage, and there is one entity called giant hemangioma. Yes. In the T2, it have very bright signal. That's why, yes, Nirmin, you can talk if you like. You can just talk clearly. I can hear you. Yes, so it have in the heavy T2, very bright T2 signal. So it go with differential with cyst or cystic metastasis. We mentioned last session about neuroendocrine tumor and how we can approach these cases, and myths, sure. Sure that the most important that we know the post contrast, but take care about something which is tricky in the practice and also in the exams. If this patient have known history of cancer, then please don't rush and don't push yourself to go for hemangioma, because we mentioned that metastasis can behave like everything. Metastasis don't follow the rule. So if this patient have history of primary cancer, then it's better to put it as differential, or at least to look for the previous image. Maybe if this patient didn't have these lesions and it is newly developed, so maybe it is metastatic. Okay, so yes, it is easy to mention that it is typical for hemangiomas, but not metastases don't follow always the rule. So we have much tricky cases, and finally it is metastatic. So they mention in the textbook that it should be interrupted and should be like this, but to be honest, in the practice, don't go and rush for the hemangioma, because sometimes it looks like. Okay, let's go to another case, which is differential, sure. So calcified lesions in the liver. So you have differential, yes. Prior granuloma like TB, nice, perfect. Calcified EVM, nice. Metastasis, the most common lesion in the liver, metastasis. So calcified lesion in the liver, spleen. So you are going with metastasis. Which metastasis make calcified lesion? Very important question in everything, in exam and in the MCQ and everything. So mucinous, you should mention MM